For a standard 100-bed senior living facility, the daily operational reality is a series of quiet, compounding financial leaks. This map of a typical community shows exactly where the money is going. Total annual exposure can reach $1.15 million. This isn't a single catastrophic event, but the sum of three distinct areas where capital is consistently lost. The first source of loss is resident safety. One single fall costs a community an average of $10,000 when accounting for emergency transport, the administrative burden of documentation, and subsequent liability risks. Next is the cost of churn. Frontline staff are leaving at high rates, driven by workloads that have become unmanageable. Replacing just one staff member requires over $7,000 in recruitment and training costs, a figure that repeats dozens of times a year in a struggling facility. Finally, there are the unexpected resident transitions. When the health decline isn't identified early, it leads to a move to a higher care setting. Each unplanned move-out costs the facility roughly $8,500 in vacancy days and turnover labor. These figures aren't accidents. They are the measurable outcomes of a system that lacks the visibility to intervene before a trend becomes a crisis. The residents moving into these communities today are frailer than they were a decade ago. Their mobility and cognitive needs are higher, yet the tools used to track their wellness haven't kept pace. Official care plans are often updated on a quarterly cycle, but a resident's physical condition can shift in a matter of days. This creates a gap where the documentation on file no longer matches the human being in the room. When the paperwork lags behind reality, operations suffer. Data shows that 50% of care tasks fall behind schedule because staff are forced to react to outdated instructions. This disconnect between real-time needs and official records is the blind spot. It is the primary mechanism causing the million-dollar hemorrhage. To close this gap, operators are shifting toward a data-first approach. They are implementing a suite of tools designed to capture physical health indicators as they happen. The first layer is passive sensors integrated with AI. These systems use machine learning to distinguish routine movements from emergency events, like sliding out of bed. They identify unwitnessed falls and subtle behavioral shifts, triggering a visual alert pathway to a central node. The second layer is predictive analytics, focused on staff time in room. By measuring exactly how many minutes of care each resident receives, software can forecast which residents are approaching a higher level of risk. Tracking this time allows managers to abandon historical staffing models. Instead, they can allocate labor based on the actual, documented acuity of their current population. The final requirement for this system to work is interoperability. This is the technical standard that allows different software platforms to share and sync their data instantly without manual human entry. Without this constant exchange of information, sensors and analytics are just high-tech distractions. They only provide value if they function as a single, unified environment. Nursing teams will stop using a tool if it adds friction to their day. If the technology requires constant troubleshooting or duplicate entries, it will be discarded, regardless of its clinical potential. Successful adoption only happens when the technology automates the documentation process, removing the administrative burden from the frontline worker. Operators are now demanding clear financial proof before they invest. For a new system to be viable, it must demonstrate a full return on investment within its first 12 months. When visibility is integrated, the results are immediate. Communities see a measurable drop in severe falls because staff are intervening at the first sign of a balance change, rather than after a resident hits the floor. There is also a direct impact on the bottom line. Accurate acuity tracking allows facilities to capture revenue for the care they are already providing, but were previously failing to bill. Retention levels out as well. Nurses are no longer spending their entire shift in reactive mode, putting out fires that could have been prevented with better data. The facility becomes a closed, efficient ecosystem. Information moves from the resident to the record without loss, turning the blueprint we saw at the start into a model of operational stability. By moving toward frictionless, integrated intelligence, senior living operators have done more than just cut costs. They have transformed their buildings from reactive crisis centers into proactive care communities.